Welcome. We'll begin our webinar shortly. We currently have a few participants joining the webinar and we'll give them time to log in. Okay. Welcome to the second webinar for the G6PD Operations Research Community of Practice. We're excited about today's presentations. Before we jump into the presentations, I wanted to briefly review a few logistics. We ask all participants to mute their phones or computers during the presentations. This will help us minimize any background noise so that we can all hear well. We're going to be sure to save time at the end of our presentations for Q&A, so we ask that you please write down any questions during the presentation and then ask them during the Q&A section. If you have any technical issues that come up with Zoom, please alert us via the chat feature or by emailing GORCoP@path.org. We'll be available to help troubleshoot any issues. We're recording today's presentation to share with GORCoP participants who are not able to attend today's presentation. We'll also save the slides to our digital repository. Now on to the presentations. Our first presentation will be an introduction to quality assurance and G6PD testing, which is designed to serve as first discussion for quality assurance topics that will be further explored in the future. We'll also have a presentation focused on quality control reagents for G6PD point of care testing, and we will conclude with Q&A with today's presenters. I'm pleased to introduce the presenter and host for today's webinar, Germana Bancone. Germana joins today's webinar from Thailand, where she is a research scientist at the Shoklo Malaria Research Unit. She leads the activities of the hematology laboratory of SMRU in support to both clinical and research work. Her main research interest is the study of inherited red blood cells disorders, IRD, in particular G6PD deficiency in relation to clinical outcomes. Before moving to SMRU in 2010, Germana worked in Rome and Burkina Faso studying the evolution of hemoglobin variants of West African populations and their impact on the capacity of Plasmodium falciparum to transmit from humans to mosquitoes. She also characterized G6PD mutations in African populations in Burkina Faso, Madagascar, and Rwanda to study protection against malaria and drug-induced anemia. She obtained her PhD in genetics and molecular biology in Rome in 2008. Thank you, Germana, for presenting today. I'll turn it over to you.
Thank you, Celia. Hello, everyone. Today, I would like to talk about quality assurance in G6PD testing. And when we decided to give this presentation with PATH, we agree that this would be a presentation mainly aimed at raising the topic for discussion. And so we hope that the question that will be raised today can be useful to also share ideas about quality assurance. Next slide. So the outline of my presentation, it would be, I'll give a definition of quality assurance and quality control, and then I'll give a couple of examples of how this can work when we move from lab to the field. And then I'll have more questions about when we move from research study to a bigger program. Next. So I use the definition of quality assurance from CDC, which is quality assurance refers to plan step-by-step activities that let one know that testing is being carried out correctly, results are accurate, and mistakes are found and corrected to avoid adverse outcome. Quality control is one part of the QA program. So this definition includes the tests are carried out correctly, which means that they are performed by trained user that follows the procedure for sampling and testing. When we say results are accurate, this implies that the quality of the testing device is good and the quality has been maintained through shipment and storage, and that the results are interpreted and reported correctly. And mistakes are found that really refer to mistakes that are found in any of the analytical steps. Obviously, this definition can be applied to any testing, but if we consider G6PD testing in particular, we need to consider that especially now where we are transitioning from the lab to the level of workers, we will be facing problems that are related to the different setting. And also the fact that some of the G6PD tools, especially the quantitative one, are more complicated because they measure an enzymatic activity normalized by hemoglobin, and this might create more challenges in terms of QA/QC. Next. So I think many of us have done research in G6PD in the lab mainly, but many of us are also moving to field situation. And this could be more like a semi-field condition with a laboratory that still can train and have skilled technician, but also to the level of the community where there's really no infrastructure, and we're talking about health workers doing the testing. And obviously this means that we all lead our research projects using probably slightly different protocols and also slightly different QA/QC systems. And in the last few years, PATH has promoted and supported the harmonization of protocols in the lab. And that meant that actually right now we can actually compare results across countries. And so these efforts should be now also brought to the activity that they are moving to the field. Next. And so if we want to summarize the approach for QA in this situation of field clinics or community, so we would first do a training for the users, and that would include all the phases of the testing, so pre-analytical, analytical, and post-analytical. And the pre-analytical, we would not only take care of what needs to be prepared before the test can actually run, but also how to take care of the proper appropriate test storage. The analytical part is obviously when the test is performed, while the post-analytical part not only includes the interpretation and reporting of results, but also troubleshooting. After the training, we would usually do an assessment of user proficiency, and this can be done with different tools. And there might be a time where at the beginning where the use of the test is still supervised. And in these three phases, especially if we are introducing a new test, then it's probably the good moment to do questionnaire or focus group discussion, especially if we want to gather more information on the usability of the test, or if we want to test whether our training and training material were appropriate, so we can still improve it. Now, after this phase, we would go into the actual testing phase where the use of the test would be mainly unsupervised. And that's where we would implement some sort of QC. This depends also from the setting and the situation, but I would say that there are different strategies that we can use. We can use a daily or weekly on-site QC where the user would utilize some of the controlled samples that can be available. And this will help the user also check frequently whether the test is going okay. But then we can also organize a post-analytical QC where, for example, the RTTs are sent from the community back to the central lab, and there they are inspected. Or we can organize an external QC where samples with known characteristics are sent from a central lab or a central national lab to field settings, and then the test is performed there and the results are then compared to give a feedback. Or, especially in the community, the supervisor might organize regular QC visit where he goes and check both the testing material and even the proficiency of the user. Then the last part would be needed, the refresh training, to keep the quality high over time. And this can be done by scheduling training or by repeating training when the QC showed that this is needed. Now, the first example that I brought here is not about G6PD testing, but is about malaria RTT testing. And I think that's useful because although it's not G6PD, it still gives us some insight on what we could use for the G6PD testing. In this case, this was an activity carried out in the community for the malaria elimination program. And the BioLine PFPV test was used. You can see a picture of it. It's a standard malaria RTT. You have the blood well where you will load the blood sample. Then you have the buffer well where you would load the buffer, and then the blood would migrate. And then you will have a control line showed when the test is valid, and a PV or PF for both lines showed depending on the sample. Now, for this study, the reading SOP was to let the background clear before reading the test. This would be between 15 and 30 minutes. It was said not to read the test after 30 minutes or reread it after 30 minutes. To give a valid results, the control line must be visible, and any faint line, any faint test line would be interpreted as a positive. In this case, what was done is that the RTT were shipped back to the central lab maximum 3 months after the test was performed. And so this was a post-analytical QC. And then in the central lab, the team would inspect the test for control line that should be visible up to 6 months. They would observe if there was blood in the sample well, around the sample well, and they would inspect the general condition of the test in terms of when the time was recorded, the labeling, and also other aspects of the test that might show whether the test was well run, and obviously if there was blood migration. Now we know that all these tests, most of the malaria tests, they have backflow. So obviously the blood migration can be checked to a certain extent. So the results of this post-analytical QC showed few interesting points. The first one was obviously, since there is all this backflow, one of the questions is like, is this even an appropriate way to QC this sort of test? But then if we think about G6PD testing, then the other question is whether we only want to use tests with the internal control line and tests that may be even stable enough or allowed for post-analytical QC. In a number of samples, there was still blood around the blood well, and this might indicate that in fact when the blood was transferred to the test, not all the blood was going inside the test. And so the question is whether this is just a training problem, so we just need to teach better the health worker to how to transfer the blood. But also, I wonder whether the blood transferring devices are good enough, and if there's any check on the quality ever before being deployed or even after. The other thing that we observe is that although it was explained that the reading time really depended from when the background was clear, in fact, the vast majority of the health worker would read the test either at 15 or 30 minutes, which wasn't bad, but then he also gives an insight into what it means to let the health worker choose the time. In fact, it seems that they don't want to choose the time. They want to have a clear indication of when the test needs to be read, which means that we also want to employ a test that is very solid and can actually give accurate results at a fixed time. Next slide. The second example is about G6PD testing, and it's about the as the biosensor. So most of you will know, but this is a biosensor machine composed of a reader and of a test device, a strip that we can use for each sample. In this case, we will sample the blood, we will mix it with the provided buffer, and then the mix will be loaded on the machine, and we will have our results in 2 minutes. And the results will show the G6PD activity normalized by hemoglobin and also just the hemoglobin reading. This tool comes also with 2 levels of control samples. They are in the form of a lyophilized ball shape, and they can be diluted in the buffer and then tested exactly as a normal sample. We have used extensively this biosensor in our laboratories, but we want to try to bring it to the community. But knowing that it's a slightly more complicated test than an RTT, we decided to do a stepwise approach and to first train lab technicians from other labs, and then to bring it to our semi-field clinics and to train health workers there, who are probably better trained than the health workers in the community, mainly to try to see if our training materials were good and if also the machine was stable outside the lab. And so the QA plan for this pilot was to use the level 1 and level 2 controls every week at the beginning of the week, and if and to advise the health worker to use the machine only if the results were within the provided ranges. And then every day the temperature of the place where they were running the test was checked twice. And we would keep machine and test strips at room temperature, which it actually reached 45 degrees. And so we decided that we would keep the controls in aircon room, although this isn't required, but we were still piloting, so we wanted to make sure that our control sample were stable. Next. And so we follow the same approach I explained before. We prepared the training material. In this case, we have to translate every material from English in other 3 languages that are the local languages spoken by our health workers. We prepare a simplified SOP made only with pictures and very simple explanation. And we use mainly this for training and for visual aid during the testing. And then we prepare the full SOP in the local language and English. And then we use a modification of a questionnaire the path had developed to assess usability of the test, to which we add another part that we could use for proficiency assessment. After preparing the material, we train the trainers who speak the local languages and could go and train the health workers. And then we organize a 1-day training, followed by a day of user proficiency test that included both questionnaire and supervised testing. And then we let the health worker use the test during a couple of months, and then we have analyzed the data. Next. So again, since the main aim was to validate the training material and at the same time also to confirm the machine was still working, I summarize here 3 points that we observed that I think is worth discussing. Obviously, when we train anyone, really a group of people, we would see that there is different skills that we observe. In this case, it wasn't different, but what we observed in the unsupervised use was that the health worker who showed to be less confident during the user proficiency in the questionnaire actually did the test only once during the 2 months. And so this brings a question about when we are going to employ a new test, being a new RTT or a more complicated quantitative biosensor, for example. How do we assure that this test is actually performed whenever it's needed? And if it's more complicated, whether the health worker won't be scared to use it? The other thing that happened was quite interesting. So the health worker that we train in the middle of these 2 months, they trained another health worker that came back from maternity leave. And this, we only knew it later on. But in fact, discussing about this, it seems that especially in the community, this might happen quite often, that the health worker would train his peers and then let them do the testing. And so obviously one wonder really, how do you keep the quality when you're not the one who provides all the training? And the last thing that we observe is that 1 week the quality control failed, and the health worker were really confused because they didn't know what they should do next. And in fact, this happened even before in the same clinic, but with lab technicians, when we were still using the normal quality control for the fluorescence spot test for G6PD. And this test wasn't very stable, so in fact, at a certain point where it would fail, we would start to have very weird results. And we decided that we would stop using it and do other sort of quality control. But obviously the question remains, if our quality control samples are not stable of the problem, how do we keep the quality of the testing? Is there any alternative if the quality control fails? Next slide. Now, this is few discussion that we can make about the training and supervision and the testing in a relatively small scale. But then when we move from this research study to bigger program, national global program, there's obviously a much larger system for quality assurance that goes from the diagnostic test qualification to lot testing and distribution, and goes also behind the normal troubleshooting with the monitoring and a post-implementation monitoring. So I don't really know much about this because I've worked mainly in the lab. I think that maybe we can take other QA program as an example when we want to build our G6PD testing QA program. And obviously the first idea is about the global malaria program. Can we use some of the tools that have been set up for this? And I don't know, maybe some among us can answer this. Are these tools really used? Are they effective and adaptable, like the pre-qualification program, the testing program, the positive control well that was developed by WHO and FIND, the protocol on responding to problem with malaria RTT? So it would be really nice if we could discuss more about that. But then there's also probably things that we really need to develop from scratch for the G6PD testing. The first thing that comes to mind would be the genetic counseling, because when we tested G6PD, we actually testing a genetic disease. Next slide. So in conclusion, just to summarize my question, we really want to discuss about quality of tests and controls and the implementation. So about the quality of the test and the control, we'll have some answer in the next presentation from Maria. She would talk about the control sample that we maybe can use. Well, for the implementation, apart using other QA system, we maybe will need to discuss about reference labs and what we really need to set up for the G6PD testing. And one question that I have thinking in practice when there will be health worker using malaria RTT and G6PD RTT in the same place in the same moment, we maybe need to think about other practical problem. Very simple thing like maybe we need to have very clear distinction in the shape and color of our testing a buffer so the health worker doesn't mistake one buffer for one test. Next. And yes, that was my last slide. I'd like to thank my colleagues at SMRU, especially Stefan and Lepo, who run the QC for the malaria RTT, Jill and Wayne and Tabitha from the malaria elimination team, and the diagnostic team at PATH. Next slide. And I'm really honored to introduce Maria, who's the next speaker today. She's a research scientist at the diagnostic department of PATH. She specializes in developing technologies for preserving biological specimens, which include red cells, yeast cells, and recombinant protein. And she was critical in developing and now maintaining the repository for preserved red blood cells. Thank you. Please, Maria. Next.
So my part of the talk is about the quality control reagents in supporting point-of-care G6PD assays. On the next slide, we have some guidance from the World Health Organization for using diagnostic assays and using quality controls and running the assays. So the first comment is that the quality control samples should be used in the performance of each assay to show that the test is valid and the results are reliable. And the second point that the WHO makes is that the quality control samples are used to validate the test run. So therefore, they should be treated in the exact same manner as the test samples. And the third point they make is that each lab should develop some criteria for run acceptance based on the guidance from the manufacturer's kit and in-lab validation for the external quality control sample. And the last point they make is that it's best if the kit controls are provided with the kit as a negative and positive control, and if a quality control sample is provided with a low positive externally produced sample. And they would be optimal as far as running quality controls for the test. So currently there are external quality assurance programs for G6PD screening, and quantitative tests do exist, primarily though for reference labs. And examples of this are available in Taiwan and in the Philippines. And the UK Nexus, or the UK National External Quality Assessment Service, does offer external quality assessment of diagnostic tests.
So this slide is showing analytical control systems, which is commercially purchased controls for G6PD testing. They come in normal, intermediate, and deficient activities. And I want to point out, just looking at the slider, you can see quite quickly that they're not field deployable, mainly because the lyophilized form needs to be stored at 2 to 8 degrees. And once it's resuspended, it needs to be stored at 4 degrees, and then after a week, it's tossed. So what happens is you resuspend it in 500 microliters. In a given week, if you do quality control testing for a week, you might use 70 if your test requires 10 microliters. You might use 70 microliters. There is a lot of waste. We never consume the 500 microliters in a week. So that's currently what is available on the market for G6PD quality control. Next slide, please. So we have taken recombinant G6PD and lyophilized it, and you can see on the right there with the green that it is field deployable. We've looked at these controls for a year, and they're stable up to 45 degrees Celsius. They're single use. You can get 5 to 10 assays per vial, and the resuspension volume is a lot smaller, 50 to 100 microliters. So they're quite useful to be used in the field. Next slide, please. This is showing the workflow. So if you look at step number 1, this is a picture of the lyophilized control in a little Eppendorf tube. Step 2, you dehydrate with deionized water. Step 3, you wait about 10 minutes, and now you run the controls as you would run the test sample. And we've been able to show that this works in 2 qualitative assays. We've used it in the fluorescent spot assay and also in the CareStar. Next slide, please. Here are the results. So if you look at the right side of the slide, there is the CareStar test for G6PD testing. N is for the normal G6PD control that was used, showing there's a pink result there. The intermediate is the middle test, showing it's less pink. And the third test on the right there with the D is deficient, showing no color at all, showing that there's no G6PD activity. On the left side of the screen is the fluorescent spot test, and if you look there, the test is divided in thirds. So the first third is 0 minutes, the middle third is 5 minutes, and the last third is 10 minutes. So the top row then is the commercial control, the normal control, showing at 10 minutes it's bright. And the second row is my reliabilized control, showing its normal control. It's comparable to the commercial control. The third row is showing intermediate activity, and you can see it's fluorescent. And the fourth row is showing deficient activity, showing it's dim. And the B, please go back. The B and the second Whatman paper is showing that after 1 year of storage, the controls have the same activity, showing that we have preserved the activity after 1 year. Next slide, please.
Hi, Maria. Sorry, Maria, before you go on, apologies for the interruption. If others could please mute their phones, there's a lot of background noise. That would be very helpful for this recording. Please mute your phone. Okay, thank you.
So in conclusion then, there is a need, as Germana's pointed out, we need to have a field deployable controls to be sure the tests are working and the results are valid. These recombinant G6PD formulations can be used for qualitative tests. Keep in mind, at this point in time, these recombinant formulations cannot be used in any quantitative tests that require normalization with hemoglobin. And these formulations do not control for the functionality of each individual test. As Germana's pointed out, to know that the test is functioning, we do need to see a control window or a control line. So these controls do not make up for that. But so what would be optimal would be to have an external quality control like the lyophilized recombinant G6PD, as well as a control line. The next slide, please. Next slide, please. So what we've done here is we put together 4 different questions about what we've discussed today in trying to understand or to raise the awareness of quality control samples in G6PD testing. And so the first question is, or first statement is, quality assurance is a wide-ranging concept covering all activities that individually or collectively influence the quality of a product. So I would say that that's true. That is correct. That's what we're trying to convey here. The second question, or the second point, is that the control reagents for end users will support sustainable QC and QA framework to ensure the accuracy and robustness of care tests. And this is also true. And the best PD control agent will be in the clinical QA testing, as well as in-country lab testing, as well as staff training for proficiency. It will be, the G6 control agents will be available on all 3 levels. And also, no enzyme control will be useful as well. Next slide, please. And I'd like to acknowledge that at PATH, Chang Chen, our formulations area, assisted with the formulation development of the recombinant G6PD, and that Jose Diego de Brito Sousa performed the CareStart assays in Manaus, and that Wes Van Voorhees provided us with the recombinant enzyme. And our donors, we thank those, UK Aid and Bill and Melinda Gates Foundation. Okay. For more information, contact Germana, Maria, or Gonzalo. And the next slide is any questions or comments that anyone would like to make. Now is the time to do that, please.
So we're now.
Since no one is
Perfect.
no one is asking a question, this is Marius from Akron. Thank you for wonderful presentations. I do have a quick question. So in terms of clarification, for the biosensor test, the SD biosensor, which we do have the controls, commercially available controls. So in terms of the frequency, or I know, what would be your recommendation now if we were to use the point of care SD biosensor test? How often should we be using the controls in the field? I think somebody mentioned once a week. If maybe you can elaborate on that a little bit.
Germana, do you want to answer this one?
Yes, I can. Although, well, for us, we chose to do that once a week because we thought in that situation it was okay. But we actually haven't really decided when the test would be really deployed at the community level, what would be our requirement. Yeah, no, that's it.
I can make a comment. So we have initiated some studies right now, and we're requiring that the controls be run every day that you're running a sample, to be sure that the controls are within range, to be sure then before you run a sample that you have your controls working properly. So that's what we're instituting in our studies at the present moment. Does that answer your question?
Yes, thank you. That's very helpful. I appreciate it.
Okay.
Yeah, and sorry, this is Emily from PATH also, and if I can just add that I think this is a really interesting question that we're trying to think about, and to Maria's point, you know, in our clinical validation studies, we're running the controls once per week because our primary concern is the performance of the test and the quality of the data. And there may need to be some right sizing of that frequency to whichever whichever setting you're working in. And so one of the questions that we've been thinking about is, in particularly places who have low sample volumes and they might only see one patient every week, how frequently should the controls be run? So I think it's a good question, and I think until we have more data on field performance, we won't have a full sense of frequency of errors or frequency of issues, and so we're sort of going with our mostly informed opinion at this point. But I do think it's likely that once rolled out, the frequency of controls for regular case management may look different than for someone who's trying to do validation.
Okay, so this is Celia. I'm going to ask a question from the group chat. We had a question about what are the storage requirements for the G6PD controls?
Which controls, the commercial controls, or the SD biosensor controls, or the lyophilized controls from PATH?
Andrea and Peter, let's see. For the recombinant from PATH.
And so what was the question about the controls? The storage?
Yeah.
We store them lyophilized, and they have been tested. They're still have activity up to 45 degrees Celsius, up to a year. We've tested them for a year, so you can have them and they still work.
Okay. How about the SD biosensors? I mean, sorry, the controls for the from the SD biosensor.
They're stored at room temperature and they're good for 2 years.
They're good for 1.5 years.
1.5 years for the SD biosensor. Room temperature storage.
Hello, this is Xavier from Find. On that question of the temperature, I had a question for Germana. I noticed that SD Biosensor recommends to store the strip at no more than 30 degrees Celsius. If I understood correctly, Germana, you said that you measured temperature ranging from 24 to 45 degrees in the field. Do you think this is an issue or not?
For what we have seen, but again, the main point of our small study was mainly to check our training material. But the results we got from I would say maybe 50, 60 samples at that temperatures is that we didn't see any major decrease in quality when the strips were kept even at that temperature. So it didn't look like it's a big problem. And we've tried something, but very little, like very few strips incubated in our lab for a few weeks. And we went up to, I think, 8 weeks at 45 degrees with no problems. But again, you can consider this as the how can I say? It's just very small exercise that we've done, but we haven't seen major problems.
Okay, thank you.
Any more questions?
I had a question for the presenters, but also potentially others on the call. You know, I think one of the things that we're trying to be cautious of, or at least aware of, is that we're introducing it, you know, or in some cases, you know, expanding use of a diagnostic, the G6PD diagnostic, and there's sort of varying levels to which controls or QA for malaria testing is in place. And so I don't know if others who have more experience with how that is generally done where they're working could comment on how some of the QA recommendations for G6PD testing compares to what's done for malaria.
Mm-hmm. Hi, this is Jane from WHO Global Malaria Program. Just to respond to those questions, we have never had sort of point of care control materials available to QC or to allow for end user QC of malaria rapid tests. Xavier can probably speak to the years of work trying to develop a universal control well for malaria rapid tests, which was very challenging. We've very recently and are on the cusp of releasing some protocols to support manufacturers develop their own materials. But just to say, the reason this approach hasn't been used for malaria RTTs is because they just simply haven't been available. And that's why the program that Germana mentioned in her presentation around product testing and lot testing sort of moved things up farther to reference laboratories using well-characterized materials to assess the quality not only of the products prior to purchase, but then prior to deployment in the field. So I don't think there's not a lot of end user QC lessons to learn from the malaria RTT world. We did do a couple of pilot studies that have been published in Laos and in Uganda using them. So we know that we can train we can train health workers who are doing malaria rapid tests to do controls and to act on that information appropriately. But one of the issues that we think is a challenge to not just having the materials to do the end user QC, but to have the response system in place. So you can have the tools there, but if no one knows how to respond or what to do or how to troubleshoot, then the utility of that material is going to be significantly limited.
Thank you, Jane. That was really interesting.
Yeah, that's really helpful. Thank you.
One other thing I'll just add is that, we also, looked at this issue of how often to do the controls, okay? Whether it was daily, every time you open the box, when you get a new lot, when you have a series of negative results, so you start to doubt whether or not the test is working. And we also did interviews with a number of people in national programs in different countries. And so we're happy to share that with you to see how that might inform this work going forward. But the bottom line is, I think that it's going to be difficult to be highly prescriptive. And that ultimately the use of these control materials at the end user interface is going to be determined by the resources available. So as you guys know, you're using up those tests every time you run the controls. And those tests are going to cost between $250 and $350 a day. You have to train everyone on how to do the controls, and you have to have a system that can respond to them. And so, I think that's why I'm saying the resources that are really genuinely going to be available to do the QC properly and to respond to those results will ultimately inform, I think, how often and where this activity is conducted.
Yeah, I completely agree. And I just, again, I think your point about having the resources in place to respond to issues is really important. And I think, in study settings, we have flexibility to simply pause a study to do troubleshooting. But I think we do need to get to that point where we have guidance available that takes into consideration the fact that you can't pause patient care, and there needs to be other options or some recommendations about what to do when either the QC fails or, yeah. Thanks, Jane.
Okay. With that, we want to thank you for everyone who participated in the webinar. In particular, thank you to our presenters. I want to quickly remind everyone that we welcome any resources that you would like to add to the digital repository, as well as suggestions for topics for future webinars. You can email those to gorcop@path.org. We'll have another webinar in September, and we look forward to connecting with you then. With that, we'll close today's webinar. Thank you.
Thank you.
Thank you.
Bye.
Thank you.
Thank you so much.
Bye.